Welcome, everybody. We're just going to give everyone some time to settle in, but thank you for being here. If at any point during the webinar you have any questions that you'd like to direct at either Jenna or Dr. Shosha, please feel free to populate them in the chat. Very happy you're here, and we'll get started shortly. Hello. Welcome.
Hi.
How's it going?
Why does it look so yellow in my room?
I know. I don't know, but it definitely does.
Oh man, hold on. I don't know what's going on.
Oh, hello, Stephanie. We're so excited to have you all here today.
It's weird that that's yellow.
That's all right.
Well, I've got a bright O-ring on me, so hopefully that's enough.
There you go. I just told our few attendees who are here so far that we're going to give everyone some time to settle in, and then we'll get started shortly. But you look beautiful.
Thank you. It's awesome what makeup can do for you,
Oh.
especially when you are under the weather. So I always feel better when I put makeup on. It's a very weird psychological thing, I think.
100%, but you look gorgeous.
Thank you. And you do as well, as always. And I love the new haircut or the color. It's awesome.
Oh, thanks. Figured I'll be going gray anyway. Might as well just beat it to the chase.
Well, that's why I actually started putting my hair into like bleaching it out with some color because of the gray, because I was getting older and it was becoming very prominent. I don't know why it is so yellow in this room because the lighting isn't any different. I'm wondering if this is better if I have this one off. Hold on. Will that make it better?
Let's see. It's very, is the word sepia, S-E-P-I-A? It's like a color family, color grade.
It looks like that's what's going on here, but
I mean, you look pretty, so it looks good. I don't think it looks bad.
I don't know. It's bothering me though, because I mean,
yeah, I wonder.
It'll bug my husband later on too, who'll be like, "Why is this not a normal color?"
I'm going to pause the recording and we'll start when Dr. Shosha comes in.
Okay.
Shosha, welcome.
Hi, how are you?
I'm great. Okay, so now that you're here, we're going to get started. I will just say a couple of opening words and then the floor will be Dr. Shosha's and Jenna's. And just so that we're clear on the agenda, this is going to be an interview between Dr. Shosha and Jenna, and we're going to leave the last 15-20 minutes for live Q&A. So if you have any questions at any time, please feel free to just put them in the chat and Dr. Shosha and Jenna will answer them as they come. Welcome to Understanding the Canadian NMOSD Journey, brought to you by the Sumaira Foundation for NMO. This is a 6-part webinar series sponsored by Alexion Pharmaceuticals. We're so grateful to have their support. And our first webinar, which is tonight, is Pregnancy and NMOSD. We felt that this was a very popular topic in our community and wanted to get some intel, as they say, from the horse's mouth. So it's my utmost pleasure to first introduce you all to Jenna Von Amaram. She is, first of all, a lovely human being. She is an NMO patient from Canada and most recently joined the Sumaira Foundation Ambassadors team. And she is actually the first Canadian NMOSD patient to have successfully given birth amidst her diagnosis. And then, of course, we have Dr. Eslam Shosha here. He is a neurologist at McMaster University and has a keen interest in neuroimmunological diseases such as neuromyelitis optica, MOG, MS, etc. So without further ado, I am going to turn the floor over to them, and I'll see you guys later.
Excellent. Thank you very much. And Sumaira, if you wouldn't mind making me a co-host, because I do have our intro video that is a quick 2 minutes that I'd love to show everyone.
You got it.
Fantastic. All right. I will start with this quick little video, and hopefully that gives you a bit of an overview of who I am.
When you're first diagnosed with NMO, there's a lot of uncertainty. What will my life look like? Will I have a relationship? Can I have kids?
Hello everyone, I'm Eslam Shosha. I'm an assistant professor at McMaster University and neuromyelitis optica and multiple sclerosis.
My name is Jenna, and I've had neuromyelitis optica spectrum disorder for 11 years. When I had my first attack, we were 4 months away from our destination wedding. My husband and I always planned to have children, but with NMO, you can be robbed of that possibility.
Hello everyone, I'm Eslam Shosha. I'm an assistant professor at McMaster University and neuromyelitis optica and multiple sclerosis specialist. Neuromyelitis optica is an autoimmune disease that
I'm beyond grateful to the researchers who provided us with information on NMO and pregnancy. Sophie is 8 years old now. I'm a lot like other moms. I worry about typical things. But living with NMO adds extra parenting challenges. So as a family, we've decided to live our best lives together. I believe I'm the first Canadian NMO patient to have had a successful pregnancy. I'm hopeful that with more research and greater discussions, many more will follow.
There you go. A quick little intro, and I'm so sorry. I'm using some new technology, and it looked like it cut my edits off there. So I will put into the chat a hyperlink for those who'd love to see that video again. Are you there, Dr. Shosha?
Yes, hi, yeah, I'm still there. Thank you for the video, and thank you, Sumaira Foundation, for supporting the idea of this webinar. And thank you, Alexion, for their commitment towards the community and the neuromyelitis optica patients group in Canada. I think we are all in an exciting time regarding the new medications that we are all having. Had been centuries that maybe not a lot of people, they don't know that neuromyelitis optica had been for more than 150 years. And finally, we are having some light at the end of the tunnel with the first ever approved medications. very important topic that touched the patient's life, and not only themselves, but also their partners, having the pregnancy, carrying a lot of concerns regarding having kids or transferring the disease from themselves to the kids, the dogma of continuing on the medications, and the lack of expertise that they are familiar with those immunosuppressant medications that they require special follow-up and special recommendations. Added to that, the neuromyelitis optica is a rare entity. So unfortunately, we lack the clinical trials that includes the neuromyelitis optica while they are pregnant, and majority of the clinical trials that when they run for new medications, they exclude pregnant ladies or pregnant patients in their trials. I'm delighted today that we will have and hear from Jenna about her experience with pregnancy. And I hope, Jenna, after this interview, you wouldn't find someone else that he will claim that he was the first before you, and then you will lose this title.
You know what? I've been looking for a while, and was secretly hoping that there was someone else, because it would have meant that someone else would have gone through it before I did. But that wasn't the case. So as you saw in the video, Sophie's 8 years old. Her birthday is July 31st. So if anyone is out there who has a child with the NMO diagnosis who is older than that, then I will happily relinquish that title.
Okay, so that I would like to hear from you, like, when was your first symptoms and how you got diagnosed before we move to the pregnancy plan?
Yeah, so I am 39 now, and I had my first diagnosis, first symptoms really, I would say, probably when I was in my early 20s. Now, we didn't recognize them as NMO. Looking back, there were a couple of incidents that happened where I'm pretty sure there was some paralysis and it came back. So it was years later, in 2009, when I had my very first major attack, right? So that was a transverse myelitis attack. And as you saw in the video, is unfortunately 4 months before our destination wedding. And that was tough because, I was, this is where it gets difficult for me because I have to be very vulnerable. But, instead of thinking about walking down an aisle, I was thinking about learning how to walk again, or even ever again, because that's what they had told me. And I was unfortunately one of the patients who, when we did the blood work and it was sent to the Mayo Clinic, it came back inconclusive. So I wasn't actually diagnosed with NMO until January in 2010. So a couple months later, when I had an optic neuritis attack. And, obviously you have to have both of those in close, in a close time frame to be diagnosed with NMO. And that's what really flagged it for them.
Yeah, time really changed. Like since the 2015, we don't need to get any two attacks. The progress and the techniques that they are using for the antibodies now, we can diagnose neuromyelitis optica even from a single attack if the antibody tends to be positive. So it's much more dependent now on the antibody status than on the symptoms. And this gives a really opportunity for patients and for physicians that we can start medications early, and we have an early diagnosis with a clear plan down the road. So maybe during this time, Jenna, I think as the majority of the patients, the main concern for you was wondering about how the disease would behave, what are the relapses or how you would recover. And maybe nobody, or it wasn't the main concern by that time that you discussed what is your family planning or what is the suitable plan for you to get a kids. So how things run by that time for you?
Yeah, I think it was a difficult time because, as I mentioned, we were in that blissful state of planning for our wedding, and we both knew we wanted children. It was one of those discussions we had early on in our relationship, and so I think while we both have very full lives with our careers and with friends and family, I think the idea that we would have children didn't seem like it was something that wasn't obtainable until they took it away, and I was told it was definitely not a possibility. And I'm one of those folks who doesn't do well with no. So I I didn't settle on too bad, so sad. I decided to ask around, research, and I'll be very transparent that we did end up getting married in July of 2010. So several months later, past where we were supposed to. And it never occurred to me for a moment that we wouldn't at least try. And the initial reaction from the neurologists from our medical team was a flat out no. There wasn't enough information. I was on a lot of new medications. I was suffering from all of the side effects. I gained quite a bit of weight from the steroids. And a lot of the medication they were trying, I wasn't tolerating. And so it was a pretty definite flat out no. And I'll tell you, it was devastating because I think we'd always thought that was just something that we would get to do one day. It hadn't ever really occurred to us that that could be something that could be taken away.
So just like, before you go to the first attack, have you ever got pregnant before that, or have you had like any miscarriages before the first attack?
Yeah, again, being very vulnerable, we had a miscarriage early on, a couple years before that, and never really thought anything of it other than, it wasn't meant to be. And I was obviously very devastated, but we worked through it, moved forward. And it's incidents like that that really kind of solidified in my mind that it was something that I would love to do one day, is to be a parent. And I think so for my husband, for Mike as well. But looking back at it now, I certainly wonder if, a undiagnosed NMO diagnosis is the cause for that miscarriage, for sure.
Was it just only one miscarriages, or you had a couple of them before the first attack?
I did have a miscarriage from a previous relationship. And I was, and that was something that we had tried for. And then my husband and I, we had the second miscarriage. And then since then, just last year, actually, we've always been open to the idea of having more children, and unfortunately had another one. So I think we're at that point now where we're pretty confident that we're very blessed and happy with Sophie. But I'm certain that miscarriages are just part of the course now, unfortunately. And you're the expert, so perhaps you have some insights on that.
Yeah, so I ask you about that because neuromalacia optica, usually it doesn't come, it can be like as a single disease, but usually as part of the autoimmune process, there might be accompanied by other autoimmune diseases that can lead to miscarriages, frequent miscarriages. Like antiphospholipid syndrome, that's a common autoimmune disease that usually can be associated along with neuromalacia optica. But at the same time, as you mentioned, that you might have an underdiagnosed neuromalacia optica. By that time, I didn't have a disabling attack, but the antibody was there. And maybe a lot of people, they don't know that the aquaporine channel, which is the antibody attacks for neuromalacia optica, this protein channels, their job in the brain or in the body in general is just like transferring water. It's the transport channels that water can go through, and either in the brain or in the kidney. But it will be surprising for a lot of people that normally the placenta has the aquaporine channels. So if the patients have the antibody, that they will be liable that those antibodies can attack the aquaporin channels in the placenta, and it can lead to miscarriages. One thing also worth to mention is that those who started with, they have miscarriages before the diagnosis, or people they have the neuromyelitis optica diagnosis, when they retrospective, they go into the history, they found that they have frequent miscarriages compared to the general population. So I assume by that time nobody investigated why you had frequent miscarriages. If they sent for any other causes apart from the NMO, the antibody wasn't available, but they didn't look for any other associated diseases.
No, I mean, up to that point of that first major attack, there was no reason for them to investigate. You know, to the best of their knowledge, I was a healthy 20-something-year-old. I used to be a dancer, so I'm quite athletic. You know, I used to run. I used to be a ballerina, and you know, I love to try, extreme sports. And so it was something that never really occurred to even me to consider that there was something wrong. You know, I mean, quite frankly, I just assumed it was one of those things that, you know, it happens. And I assumed that it wasn't related to any sort of upcoming disease. And in fact, this is something that's new to me that I'm learning about, because I wasn't even aware that that was a possibility, thinking back to even last year with the miscarriage that we had then.
Well, as we are on the same point, that's just like to mention that neuromyelitis optica, when they have miscarriages or abortions, they are liable to have more frequency attacks after that compared to the previous of the pregnancy. It's something related with the releasing of the antibodies and the hormonal changes that comes with the abortions. Maybe before we move to the medications, I might add something here for the patients, or because like a lot of patients, when they got the diagnosis of neuromyelitis optica, the most common thing, or the most common the disease that they compare with is the multiple sclerosis. So, and it's very important that to understand that neuromyelitis optica behaves different from multiple sclerosis. Normal for every pregnant lady, there are some hormonal changes that leads to immunological disturbance in the body. And just to simplify it, so we have subset of the lymphocyte, special subsets of lymphocytes. We can arrange them in two groups, group 1 and group 2. So what happens in pregnancy, like for normal populations or normal patients, that the group 2 becomes more than group 1. So they have shifted towards the group 2 more than group 1 in normal pregnancy. And actually this mechanism or this behavior in pregnancy is protective for multiple sclerosis, because the group 1 is the causative problem for the immune disturbance and multiple sclerosis. But in neuromyelitis optica, group 2 is what's causative the disturbance in the immune system. So that's why pregnancy can trigger neuromyelitis optica, and it's different from multiple sclerosis, that it is protective for the disease rather than that being non-pregnant. So once you have by that time when you got the diagnosis, do you recall which medication have they started you on?
Yeah, so I've been on quite a few different ones. Rituximab, unfortunately, is not something that was made available to me being in Canada. As an adult already, when I was diagnosed, the funding just isn't available. And so I was tried on Imuran, and it didn't sit very well with me. I was on very high doses of steroids, Solumedrol, for quite a while, and eventually we settled on Cellcept. And an interesting thing is that I was on a higher dose of Cellcept than I was on after pregnancy. So I was on 2 milligrams a day, which was, my neurologist debated being actually too low considering the severity of the attacks that I had. But I couldn't tolerate any more than that. And then, we had to go through an entire weaning process to get off of Cellcept. And when I was done breastfeeding my daughter and I went back to Cellcept, I have never been able to go higher than 1 milligram. And so the way they've explained it is that pregnancy in a lot of ways may have reset my body. And to your last point, what's really interesting is that when I think back to 9-10 years ago when we first started having this discussion, they had originally thought that pregnancy would interrupt the disease for me, similar like it does for MS. So it's very insightful for me now to even hear later on that that's actually the exact opposite, that it would actually, very likely cause a flare for NMO patients. And that actually makes me feel far more grateful for the medical team I had on board, and just, really counting our blessings, because we did not have an attack during our pregnancy, had a very uneventful C-section, and and I breastfed my daughter for almost 5 months. So all in all, during all of that, there was never a flare or any sort of symptoms that kind of popped up. And I'm really very, very excited to hear that that didn't happen to me. So but that's really useful information. A question for you then is for the other patients who are considering it, what could they do to mitigate that risk for them now?
Well, this is a good question, and actually you highlighted a lot of points or triggered a lot of questions in the last minute with you're saying this short story. So maybe I would start first by that it's very important that maybe we would say, like, retrospective, we all look smart. By that time, like 10 or 15 years ago, there were not a lot of information about neuromyelitis optica. And we are still learning more about the disease, how it behaves, the various presentation and the rare presentation of the disease that we know, and we learn more about pregnancy and how it behaves. So what usually I do is that when I have young patients or young couple, that I consider which medication I choose for them at the beginning, because I don't want to go in a dogma at down the road after this got stabilized, and then they told me, okay, we're planning now to go for to conceive or to get a kid, and then we need to change the medication and to reset the clock again. And this might upset the disease and having like more relapses. So choosing the medication properly at the beginning is very important for patients that they are considering family planning. Maybe important point that I would like to say that our physicians, patients really inspired us to look on things that we might not aware of, or things that were undiscovered. The first a couple of years ago, when we published at my clinic the first practical recommendations for neuromyelitis optica with pregnancy, from day one till the postpartum and the breastfeeding, it was actually inspired by one of the patients that, and she came and she said that I don't want to have kids. I'm afraid to have kids because of the disease activity. I don't know that what I'm dealing with, and she started to cry. And I think this is a common scenario. A lot of patients, they decided not to have kids with something that they wish or they were looking for, even with the initial relationship, as you mentioned, because of the disease. Or unfortunately, some of them, they decided to get an elective abortion because they don't want to carry the risk of having any disability down the road because of the pregnancy. So it is having kids, it's right for everyone that who is looking for it. And our role and our goal is to help the patient according to the best available evidence and according to the best information that we have, and get an understanding what are the consequences, or what are the expectations, the real expectations. So we should have real expectations. What are the risks? But at the same time, it's not an absolute no. And it is yes with calculated risks. So it's different from patient to patient. It depends on the patient profile. So back to the point of the medications that before we having the FDA approved medications that they got, so far in Canada, we have 2 medications approved, but over the globe, we have 3 medications approved. So before that, we're using the medications that they were used in the other autoimmune or rheumatological diseases, like azathioprine, the long-term steroid, the Cellcept, or the Rituximab. Some patients, they went for higher efficacy medications, like if they have an aggressive disease, like the cyclophosphamide, or the cetoxan, or mitoxantrone, or methotrexate. So considered one of the strongest medications. So we approach like we stratify those medications if they are compatible with pregnancy or they are not. So if we're starting with the new patients from the beginning that should never been on any medication, so I would prefer to go with the things that they are compatible with pregnancy, like azathioprine, a lot of data that we have. So what we are all talking about, that we don't have a dedicated trials on those medications for neither for NMO or for the pregnancy, but from the huge data what we have for years now that have been used either in MS and neuromyelitis optica and other disease like SLE or certain types of malignancies, that the azathioprine can be given and the patient can get pregnant on this medication, and she can continue the medication during pregnancy through the whole journey.
So what you're saying really then is that for patients who are of a certain age, we should be a bit more aware of our family planning strategy, because it will impact the types of medications that our neurologists are more likely to recommend as a starting point. And to your point, I think you mentioned, that you have some patients who, have considered that, having children isn't an option for them, and have even gone as far as to have an abortion. I mean, it's a very emotional decision to make. I'll tell you now, from a very personal standpoint, my daughter's 8, and I still worry about being a parent, right? I mean, from my video, I did say that there are times that I do worry. There are some extra parenting challenges. And a big thing for me really is if I were to have a flare, and unfortunately I just had a recent one in May, it takes me out for quite a while, and my husband suddenly becomes a single parent, right, who is raising our child and working full time, and then of course becomes a caregiver to me. And so that's a lot of burden. I certainly feel a lot of guilt, and as a parent, I think you worry about those things, and it's something that regular parents don't have to worry about. I mean, you have to kind of take a step back, and whether or not you've made the decision, I think, to have children, you should at least leave the door open. And it's exciting for me to hear that the neurologists and the doctors now are open to the idea, which is a lot different than when I was, at that age and thinking about it, because I just got a flat no. And that's exciting to me. And, you can always make that decision later on if you decide to be a parent or not. But it's a good strategy, I think, then to think about the medications up front in the event of, right? And one of the things that really kind of breaks my heart is when I see some younger patients, those who are, like teenagers or early 20s. And I think back to myself and my experience, and, I have their parents reaching out to me, and all they're trying to do is make sure that their kids are okay, but they're also thinking about their futures, right? Will they be able to have a relationship? Will they get to go to school? Will they have full careers? Could they become parents? And the answer is yes, for me, across all fronts, right? Anything's possible, but you do need to have a really great strategy. And that's really great to hear that your team at least is really open to that idea from a starting point, for sure.
Yeah, it's all about, it depends on the patient's profile, and every patient has a different story from the other. Maybe one of the difficult situations that I faced once, that a patient with neuromalacia optica, and she's on a wheelchair. She had a paraplegia, that both lower limbs with zero power. And she came to the clinic and wondering that if she can conceive, if she can get pregnant. And it stayed like for months, like with this discussion, like with a lot of neurologists, that they felt like from neurological point of view, that you had already a disability with a huge impact in your life, that if you really want to take the decision for that. But at the end, she decided to go for that, and she had a kid. And it's a multidisciplinary team. It's not only the neurology decision. We have to have a good plan for the patient, with the neurologist, with the obstetrician, with the anesthesia, and with her partner as well. So a strategic plan for each patient is different. So just like to mention, like the medication that you were on, the CellCept, it's not compatible with pregnancy.
It's not.
So
No.
yeah, and I understand by that point that maybe that you'd have limitation to get an access to Rituximab, which is another medication that can be safely used in pregnancy. But CellCept, as an example, is that it's not compatible with pregnancy, and we have to stop it at least 6 weeks before looking for any alternative medication or conceived plan. So maybe important point that related to the CellCept. Do you remember if you were taking any, if you are using any birth control methods during taking the CellCept?
Yeah. So from the moment that, I was diagnosed, we certainly started on our family planning, and also being very careful because we weren't sure what my future looked like, right? I mean, imagine, a young couple that was supposed to be getting married and thought that they had the whole world in front of them, and then the next thing you know, I'm literally urinating myself in front of my future mother-in-law, right? So it's a very big turnaround. It's a 180, and very devastating. So we were very careful. That being said, we made the decision, and of course, with my entire team, we worked with a high-risk IVF clinic out of Mount Sinai Hospital, and they all agreed very carefully that we would proceed and try for IVF. But it was very scientific. So I will tell you that my pregnancy was not my pregnancy. My pregnancy belonged to a team of probably 20 medical professionals, and my family and my husband. And I got very comfortable with the idea of a lot of people poking at me on a daily basis, sometimes more than once a day. And it was just something that you have to put yourself into that mindset, that if this is something you want, and it's important to you, eye on the prize, right? And that's all we focused on. So we had to wean me off of CellCept, and I really kind of thought of myself as like a science experiment, right? So I mentally, I have to be okay with this, and physically, my body belongs to scientists and to doctors and researchers, and we're just going to work on getting pregnant. So we weaned me off of CellCept. It was a very scientific process. We weaned it off while at the same time ramping up the oral steroids. And then I think it was 8 weeks for us. There was an exact date that was like, you are in the clear. And before I could have a flare, we started IVF medication. So we did the injections and had to move very quickly to produce enough eggs, do the retrieval process, right? And then to start that entire process. Now, one thing I want to mention for all of those that are considering starting a family is to have those really tough discussions early on. They're uncomfortable ones, right? But what will you do if you have an attack during the pregnancy? What will you do, if you have an attack while you're trying for a pregnancy, right? What will you do if you have an attack immediately after you deliver? So, we had to make some really tough decisions. We knew what we would do, what we were prepared to do. Um, I personally didn't feel like I could be the best parent without my mobility. And so that was a non-starter for me. If at any moment we felt like I was losing my mobility, then we would look at our options, and termination may be something we would have to do. The doctors also weren't comfortable having a natural delivery for me, so we actually had to plan a C-section. My daughter, my water broke at 37 weeks and 2 days, so right at the safe point. So while my C-section was scheduled for week 40, she decided to arrive early. So I feel a little bit better in knowing that she was born when she was meant to, as opposed to when doctors pulled her out. That being said, that was always the plan, right? To have a C-section. So I still had one when she decided to arrive. But those are just things that, having a family is a very romantic notion. I mean, boy meets girl, you fall in love, you get married, you have kids, kind of thing. And we all kind of think of that Hollywood delivery, right? Where your water breaks and there's a big drama for the delivery. And unfortunately, when you have NMO, none of that it's not like that, right? I mean, there's a lot of discussions early on, and really tough conversations, and a lot of planning for during, for before, for after. You have to have really honest conversations with family members who may not even agree, because they're coming from a place of fear, right? So they're certainly worried, and that's also a difficult conversation to have, for sure.
Yeah, I think you went very far, like as apart from the question that I was asking, because like those are like very important points, which I would like to expand in each point, so the patients can get benefit from that. So what I was asking is that which birth control method that you were using with the CellCept? Were you using pills or you were using other methods?
I believe we actually only use condoms because keep in mind, CellCept is an immune suppressant drug, right? So
Yeah.
does that render birth control pills ineffective or minimizes their effectiveness? Very likely, right? So for us, we had to use condom protection, especially while we were preparing to do the IVF process, for sure.
Yeah, so two separate points here is that the CellCept decrease the efficacy of the birth control medication, especially the hormonal medications. And so patients who decided to go for CellCept, they have to make sure that they use an effective methods apart from the pills. For the IVF, it's not open, but it seems that it went very well for you, but it's not an open option for all the patients, because like IVF it's a broad term. It has different types. There are different hormones that have been given for patients. Some of them works on the brain level. Some of them works on the uterus and the ovaries level. So we have to be cautious with selecting with those, because sometimes the hormones can trigger the disease activity. So during pregnancy, before we go to the delivery and all the things that you mentioned, so during pregnancy, how was your experience with the nausea and vomiting? Have you had any similar nausea vomiting episodes before pregnancy?
Before, I did have some periods of nausea and vomiting during some of the major attacks that I had. Then they were self-resolved. During pregnancy, I probably felt better than I did for the 2 years prior to that with NMO. I mean, the lead feeling went away in my core, and I certainly felt healthier. so I didn't struggle with a lot of nausea and vomiting, maybe the first 2 months. And, I think we were very fortunate throughout that whole process.
So before pregnancy, you don't recall that you had any bad nausea, vomiting that stayed for weeks with you?
I did, but it wasn't, excessive. I think I would probably say 1 to 2 weeks each major flare, right? So I would, and that's difficult to say if that was medication induced or if that was like as a side effect or if that was a symptom from NMO.
Have you had any hiccups with that, or just only nausea, vomiting?
Just nausea and vomiting. That being said, the last flare that I had just this last May came with nausea and vomiting, severe headaches, and then of course the horrible hiccups.
Okay, so that's very important because one of the commonest manifestation of neuromyelitis optica is something called area posterior syndrome. It is very small, it's a tiny area in the brain that's responsible for the nausea, vomiting, and hiccup center. The center is located there. So and usually it's a warning sign. It can be as an attack itself, or it can be as a warning sign prior a common neuromyelitis optica attack. So usually patients can have it for a week or two, or even for a month, and then they have optic neuritis, or they have transverse myelitis. And this really put us in a difficult situation when the patient become pregnant, because there might be a confusion between what we know as the hyperemesis gravidarum for pregnant women and the area posterior attack. So usually we mention to the patient and we alert them that if you have nausea, vomiting, or hiccups, that it's stayed and it's does not respond to the symptomatic treatment that they give for any pregnant woman, like over-the-counter medications, which the area posterior does not respond. It only responds to the high steroid, the plasmapheresis, or the IVIG. So this is a very important point. And 2 years ago, we published a criteria that how we can catch this even before the MRI. We made a diagnostic criteria and a scale for that the neurologist can go through the criteria, and he felt that the patients, neuromyelitis optica patients, they fit this criteria. So then this most probably it's an area posterior syndrome. It's not the hyperemesis that we can get it. In the literature, there are a couple of patients that before they have the diagnosis of neuromyelitis optica, they presented with this persistent nausea, vomiting, and repeated admissions to hospitals, and they thought it's a bad hyperemesis gravidarum till the patients have an attack of transverse myelitis or weakness, and then they got the diagnosis during pregnancy because of this attack.
So what you're suggesting then is that patients should try to treat the symptoms of nausea and vomiting that we believe could be from pregnancy. And if it doesn't respond to that, then we are naturally going to consider it to be an actual flare or a symptom from NMO then. Is that correct?
Yes, they have to be vigilant about nausea, vomiting during pregnancy, because it can be an attack. It's not only the normal hyperemesis gravidarum that, or the hyperemesis that all the females can get with pregnancy. It can be an attack, an area posterior attack. So patients have to be vigilant about those symptoms and to notify their neurologist that I have the symptoms, had been at least for 2 days, that it would start to concern me. And there is criteria that for how long they would stay, if it is episodes or if it's continuous. So then they have to be vigilant, they notify the neurologist, and then if the over-counter medication that didn't work, so then they have to consider going for something else. So
sorry, I just want to be respectful of our time. We have 8 minutes left, and I know that there are a couple of questions in the chat. Jenna, do you mind just giving the hosting back to me?
Absolutely.
Oh, thank you so much. And Dr. Shosha, I think that this is a good time to act. It's a perfect segue to the patient's question, actually. So I will go ahead and read it, and then feel free to answer.
Sure.
I am curious if you find NMO patients are more likely to have hyperemesis during pregnancy, and is it really hyperemesis, or could it be an NMO vomiting attack? I had severe vomiting for 7 months and lost 50 pounds the first 3 months. I was in and out of the hospital my entire pregnancy. My NMO was undiagnosed at the time. After my son was born, I lost all the feeling from my waist down for 5 months.
Oh my goodness, I am so sorry. That sounds unbelievably intense. So I'll start with that sounded like quite the battle.
Yeah, it's unfortunate. This is a common scenario that if the patients, neither the physicians are aware about this. This is what they were talking about a couple of minutes ago, the area posterior syndrome. What she described, it's the classic presentation. Patients, they have nausea, vomiting, persistent. They have anorexia, a fear of eating because they have the continuous vomiting, continuous nausea. It's unrelated. It's unrelated to food. So they continuously having the nausea, the vomiting. Even if they try to eat something, they will vomit it undigested. So, and they lost a lot of weights that, according to the study that we published, they might have with average of 7 pounds just only in 3 days. So yeah, this is very common, and it's a very important point that the patients will have to be aware of.
Dr. Shosha, is there a way that patients can access that publication just so that they can provide that to their neurologist? I think it's really important literature for us to have if you are considering family planning, so that we are aware of that differentiation there, right? And even for the OBGYNs out there to recognize that perhaps there's something else going on. I mean, I hope that there's a way we could share that publication.
Yeah, sure, absolutely. I can send it to Sumaira, and then they can get it through the foundation. Actually, there are 2 publications. One with the pregnancy guidelines, and this is highlighted as that neurologists have to be cautious with any nausea, vomiting during the pregnancy, and there is the criteria itself for the nausea, vomiting, hiccups.
All right. So our next question is for Dr. Shosha. This came in through email. In your medical opinion, is it safe to conceive whilst on Rituximab? My neurologist says it is okay, but information online says the contrary. Okay, so this is an important question, and just like might take a minute to give a brief about that. So Rituximab crosses placenta at week 16 of pregnancy. So, there is a good time for the patient that can use the medication. And there are a lot of patients, neuromyelitis optica, other diseases that they use Rituximab during pregnancy. However, that it should be planned with your neurologist, with your physicians, because there are 2 ways. Either you have a plan with your neurologist, so then he give you the medication, and then a month or 2, I would probably say 2. However, a month is okay. So a month or 2 after the medication that you can conceive. The duration of the Rituximab can stay in the body up to a year. So you don't worry that you need to take the second dose 6 months after during pregnancy, unless you have an attack during pregnancy. So then you can take the second dose. But if the pregnancy went very well, once you deliver, you have to take the dose immediately. If it's not the same day, 1 day after, not after that. However, if you decided to surprise your neurologist and just like show up in the office, hi, I'm pregnant, so then it's a different plan. We have to measure the duration of the last dose that you had from Rituximab, and then we act accordingly. Let us say you had the medication 2 months ago. So maybe there are 4 or 5 months still remaining in the medication duration. So then probably okay, I will not intervene. But if you had the medication 5 months ago and then you become pregnant and just like a 1 month remaining, so I would give you the dose and then we wait till you deliver. Rituximab also, it's safe that you can lactate, so you can breastfeed your baby while you are taking the Rituximab.
just avoid the days that you are taking the rituximab on. But then when they measured the amount comes in the breast milk were much less than any effective dose. So the answer is yes.
Great. All right, we have another question. Do you recommend bringing in pediatricians early on in the pregnancy to be aware of things like the impact of Rituxan or other medications on the newborn? Also curious if you would recommend IVF for most NMO patients. My neurologist has advised that we not use anything that can affect hormones more than necessary.
Well, the first question, the side effects that comes with the allowed medications, like the azathioprine, the rituximab, the steroid, they were not higher than that the major malformation or the congenital anomalies from the normal population. So we don't need that to get any pediatrician for any special that side effects or congenital malformation that they will have it. A very important point here that a lot of patients, they ask if the disease is transferable to the baby. If I have neuromyelitis optica, would my baby get the disease? So the answer is no. However, that if you are in a tertiary center or a specialized clinic, we would prefer to take a sample from the baby once you delivered. We have to monitor the antibody. So the antibody can be transferred to the baby, and then it just like fades away within 3 to 6 months. So they can have the antibody, but they know any kids. So up to date, maybe there are around 20 kids that documented in the literature, and none of them had the disease. The second question for the IVF, there is no preference for having IVF over normal pregnancy for neuromyelitis optica patients. So if you are not doing this for a gynecological reason or a male factor reason, so if you are not doing this, if it's because you have a gynecological problem or something related to your partner, so there is no favorable outcome for IVF over the normal pregnancy neuromyelitis optica. However, as I mentioned earlier, it depends on the type of hormone that they are giving. They're giving something worked on the brain, so we might be vigilant with that. But regular hormones wouldn't affect. But if the patient failed, you have to know. If you failed the IVF for any reason, you will be liable for relapses.
I want to point out that the reason that we made the decision to do IVF was purely because I was on CellCept, and the concern when we went through the process was that we didn't want to leave me without any sort of protection from a major flare. So the concept of IVF was introduced to us purely from a let's get pregnant as quickly as we can and minimize the amount of time that I am without any sort of protection. And I was on oral steroids throughout the entire pregnancy, and it did lead to gestational diabetes, which has its own challenges when you're on a high dose of steroid. And then, of course, my daughter was on, we were using steroids when I was breastfeeding her. And so, I mean, my preference would always be to steer away from IVF if you can. But again, it depends on the medications you're on, right? Rituximab at the time was also then considered an unsafe drug. There wasn't enough research around it. And now, it's a lot safer, and we recognize that it is okay. And so I think things are a lot different now than when I went through the process, but you need to really understand what the motivation is to do IVF for sure.
Yes, I wouldn't recommend just staying only on a steroid. Like, I think the patients need to be on medications for the entire pregnancy. It's not advisable to stop it, and steroid only in a lot of the published cases were not really effective. So either azathioprine with a steroid small dose, like less than 20 milligram is advisable. More than that wouldn't carry a harm more than benefit. Rituximab, as we mentioned, maybe like the other medications as well.
Great. And we have one more question from the audience, and then we're going to wrap up. So the question is, do you have any suggestions on continuing a treatment plan of Soliris while attempting and during pregnancy?
So Solarius is one of the new medications that it's approved, and we don't have, as we mentioned, the clinical trials, they were not allowing any pregnant neuromyelitis optica patients to have to participate in the trials. So we don't have enough data about using Solarius in neuromyelitis optica during pregnancy. However, Solarius is not a new medication to the medical world. It had been used for years in different diseases like myasthenia and some of the hemolytic disease as well. So there is encouraging data in the literature and on a couple of other diseases that they use Solarius. And I will just like approach it patient by patient. But yeah, if the patient would like, if she's taking Solarius and would like to take and she would like to go for pregnancy, so then we should have a discussion and to share the data that we have, and we move from there. But most probably, yes, she can do that, just like with crossing T's and dot I's.
Perfect. Well, thank you both so much for joining us this evening. I can speak on behalf of the entire audience that this was very insightful, and it's always great to hear from actual patients who have experienced this. So thank you for being so vulnerable and transparent with us, Jenna. I think that's really important to furthering knowledge in this area. And Dr. Shosha, of course, for your expertise, and of course, for caring for patients in our community. We're so grateful for what you do.
Oh, not at all. It's our job, and we'll be delighted to have to support any of the NMO patients for during their pregnancy if they decided to. Even if you want any support from our side to your neurologist, I would be happy to follow up and give recommendations remotely, regardless where you are.
And for our Canadian patients, Dr. Shosha, are you going to be accepting new patients into your clinic at McMaster?
Yes, we are. And actually, we have a dedicated clinic for NMO, and we are calling it the McNemo, which made for McMaster Neuromyelitis Optica patients. So we are accepting new patients. If your family physician or your neurologist need an extra information or an expert advice, I will be privileged to take care of the neuromyelitis optica patients. And especially with pregnancy, we'll have a dedicated plan with the multidisciplinary team, with your obstetrician, the anesthesiologist, and whatever other specialties that we need.
Thank you. So once again, thank you to our audience, to our amazing speakers, Dr. Eslam Shosha, and our patient and ambassador, Jenna Von Amaram, for joining us today. And of course, Alexion Pharmaceuticals for sponsoring this very important initiative to elevate awareness of NMOSD in Canada. For those who joined late, the recording of this will be available on the Sumaira Foundation's YouTube page. So feel free to subscribe so that you are aware of when it's available. We are also going to work on getting some French translation and subtitles for the video for our French-speaking patients so that you can access the information as well. Thank you, everyone, for illuminating the darkness of neuromyelitis optica.
Thank you. Good night. Bye-bye.
Thanks, everyone.